computer. Okay, it should be recording. Okay. All right. So when we talk about trauma, trauma is injury to any tissue from a transfer of energy. So typically when I ask people what is trauma, they'll say a gunshot wound, a motor vehicle accident, a fall, a stab wound, and that is true. However, a paper cut is a trauma. You know, stepping on a nail is a trauma. A burn is a trauma. So yes, it could be very major, but it could be very minor. But anything that results in injury to the tissue is considered a trauma. Now, it's a transfer of energy. So it could be like a mechanical injury. So it's, force. So again, something like a motor vehicle accident, a motorcycle accident, that's MVA, MCA, firearms. So it could be like a gunshot wound or a revolver type thing. Falls, assaults, being hit by a baseball bat, for example. A thermal, such as from heat or steam or fire. So a burn is trauma to the tissues. It could be a chemical injury that damages the tissue. So it could be a poison. It could be like poison ivy is considered a trauma, actually, because it damages the tissues. So poisonings, or, like an acid burn or something like that is considered a trauma. It could be an electrical injury. So something like lightning or getting shocked by a wire that causes burning. It could be like a radiant, for example, like a nuclear type rays that could cause it, or electromagnetic rays. It could something from the McGuire nuclear plant, for example, or also oxygen deprivation. If you remember, it causes the cell wall to burst open, and that can cause injury to the tissue, because the cell walls of the tissue, and that's what causes cerebral edema, but it causes asphyxiation, causes the cell walls to be disrupted. So actually, drownings and asphyxiations are considered traumas when we have to document them. Now, this right here is simply epidemiology, and the next slide is epidemiology. So they aren't really tested because epidemiology changes day to day. But just to kind of let you know, who do we expect to be in traumas? Who do we typically see these in? We see it twice as much in men as we do women. Why? Well, who knows why, but we think most of it is just the amount of risk. Men tend to do more risky behaviors than women do, about 2 times more. It might be because they have more risky occupations. When you look up on a scaffolding, for example, you see women up there, but you probably see more men, and then you'll see a couple women. You might see the road crew out doing things on the road and standing out there putting gravel down or whatever. I don't know. You'll see lots of men, and you might see a woman here or there, but that's when people get hit by cars. Like a lot of those people get hit by cars. So a lot of it has to do with, race car drivers. There's a couple women in there, but not a lot of women in there. And so a lot of it has to do with their occupations. That's one reason. And then there's cultural factors. I laugh. I tell the story every semester about my son when he was a teenager, and we were walking down the street, and I said, now, Kevin, when you walk with a lady on the street, you always stand on the outside. So you stand toward the curb and you put the lady on the inside. And he said, well, why do you do that, Mom? And I said, well, it probably was from the horse and buggy days, but it's safety. So if a car was to come over and be out of control, you would push the lady out of the way, and then you would be the one that got hit and not the lady, or, and he said, well, I'm going on the inside and you stand on the outside. I said, well, no, it doesn't work that way. But I say to you all, and some of you all are men and some of you are married, so you have boyfriends. Maybe you don't, maybe you don't, maybe you do, but I am talking gender here. Some of you may have same sex, but friends, and that's okay. But I'm just really talking gender. And I would say to you, when you get in a car with somebody of the opposite sex that may be close to you, who drives the car? And most people will answer that the male will drive the car. Whether it's your boyfriend, your husband, that you would say that the male will typically drive the car. Now, when you look statistically, who gets hurt in a motor vehicle accident the most? the driver of the car will be the one that's hurt the most commonly, because the steering wheel is going to come in and cause chest trauma. And so again, so who's going to be hurt in an accident the most is going to be the driver. And so again, so that makes the cultural factors that the man is typically the one that drives the car. So again, that's a cultural factor of who drives the car typically. Race is a statistic. I can't change the statistic. You may not like it. It's the way it is. The highest group that has the most trauma is the African American group. It's a statistic. About 84.9 per 100,000 in the African American, about 54 in the Caucasian race, and all the other races combined are about 73.4%. So typically we see it higher in the African American. Again, is it the occupational hazard? Is it the cultural hazard that makes it higher? I don't know. It's a statistic that I can't change. It's just a fact. Violence, about 19,000 to 23,000 per year causes of deaths are due to the violence. Firearm deaths are up by 77%. You can be NRA, you can believe in the First Amendment all you want. It's okay. That's your right. However, you can't dispute statistics. Firearm deaths in teenagers are up by 77%. And so we're seeing more teenagers die from firearms than we've ever seen die in the past. Domestic violence, we see about 1.8 million women per year are assaulted. So we're seeing more violence in the domestic, and I'll bet you this COVID's not in these statistics. I bet we will see even more domestic violence. I don't have the male domestic violence, how many men have been assaulted by women. I don't have that statistic. About 36% of all fatal motor vehicle accidents involve alcohol. So alcohol is also a huge issue. Trauma is the third leading cause of death in all ages, but it is the first leading cause of death in children. It's not up to the age of 1, but from children, which is 1 to 8 years old, it is the first leading cause of death in children is trauma. Ages 1 to 44 is the first leading cause of death are motor vehicle accidents and other traumas. We see the most of those injuries between the ages of 25 and 34. Again, those is very risky behaviors. That's jobs that are very risky. These are people out on the oil wells. These are people that are doing the most risky behaviors at that age. But if they wreck or if they have a trauma, they might not die. But if you're over the age of 85 and you have the same accident that a 34-year-old or a 24-year-old might have, you will probably die. In other words, if you're 30 and you break your hip, you probably won't die. You're 87 and you break your hip, you will probably die. Your comorbidities, the more trauma you have with the more comorbidities, you will probably die from it. About 146,000 deaths from trauma. The most we see about 28% are motor vehicle accidents. Motor vehicle accidents are the #1 cause of death from trauma. Suicide, 21%, homicide, 17.5%. Does it surprise you that more people kill themselves than are killed by other people? Mental health, when they look for funding for mental health, we got to think about that. The nightly news doesn't tell you about suicides unless you're a celebrity. But look, statistics are statistics. I can't change them. It's a fact. More people kill themselves than are killed by other people. You only hear about the ones that other people kill, not the people that kill themselves. But it's a fact. And then other causes besides motor vehicle, falls, stab wounds, gunshot wounds. Other causes are put together for other things. So there's lots of reasons, and there's lots of areas for teaching. There's lots of reasons why we have a seatbelt law, why we have what we have in place is to try to decrease the amount of trauma and deaths associated with trauma. Traumas are typically classified as severe, urgent, and non-urgent. Now, most people that have trauma with injuries are non-urgent. About 80% of all injuries are non-urgent. In other words, you could go 24 hours and not have them treated, and it would not affect your care at all. So most of the time, this transfer of energy to your tissues doesn't result in anything bad. Only about 10 to 15%, if you did not seek treatment, would progress to life-threatening situations. About 5% of all traumas are life-threatening. Now, that's not very many. I don't have the statistics for last year, but the year before at Carolinas Medical Center, a level 1 trauma center, what was classified as a severe trauma, they had 285. Those of you that work over there say, I think I worked all 285 of them. But what was classified was 285. Now, we tend to upgrade things so that we don't let them be bad. But what was really classified according to criteria, there's not a whole lot that come in as severe traumas. So it really takes a lot to be classified as a severe trauma, one that you will die within 15 minutes if we don't take care of you immediately. And that's what the definition of that is. So, you know, it takes a lot. It takes a lot to be classified as a severe trauma. But what we, the healthcare, the American College of Surgeons, who gives the criteria for what a trauma is different than what me, the consumer, I cut my finger and I need 2 stitches. It's an emergency. It's bad. It's a non-urgent. But as the consumer, my child hurts their ankle and I don't know if it's broke or not. It's important that I know that. It's not life-threatening, but I might call it urgent. It'll be classified non-urgent because it's not going to affect their care. You could wait and go to the doctor tomorrow. You could wait and go to a doc in the box when they open in the morning. That's like an urgent care center. You don't have to show up in the emergency department. But as a consumer, I want to know now. And they're hurting now. I want somebody to take care of them now. So what the consumer's view of urgent is much different than how the classification falls. So this might be how it's classified, but how we as consumers view it is very different. This was what my whole thesis for my master's was on. I just have to let you all know. And it was amazing. The findings were just absolutely amazing. Just absolutely amazing. What people felt were emergencies. So, because the consumer's view is much different than what the hospital's view is. And even you as nurses, you'll find, you'll have patients that you'll just roll your eyes at going, what in the world are they here for? You know, and they'll come in, they'll say, every time she poops, this little baby, every time she poops, her face turns red. And you're thinking, every time I poop, my face turns red. Yeah. And they bring them to the emergency department. What is that? That's lack of teaching. That's lack of education in the doctor's office or at the clinic for that 16, 18, 20, 40-year-old mother that's never had a baby before. When that baby starts to poop and they grunt down and their face turns red. But to them, it's an emergency. The face is red. I got to go to the doctor. Okay. So when we're talking about traumas, they can either be blunt trauma or penetrating trauma. And they're exactly what they say. If it penetrates the body, then it's penetrating. That would be like a gunshot wound or a stab wound or a splinter or a piece of fencing that went through the body or a stick. In the summer, when I was in the ED, we used to see a lot of wires, like from people out mowing their grass, and they would run over a wire and the wire would shoot out and it would hit somebody that was pruning bushes on the other side of the yard. And it would stick in their chest or kill them, or stick in their head and kill them, or whatever. We used to see a lot of those. You got to remember that lawnmowers are only made to protect the person that's pushing them. There is no protection for anybody else in the yard. So you think, well, you know, I would never let my child ride on a riding lawnmower because that's not safe. Well, you're right. But you really should not have anybody else in the yard when somebody else is mowing that yard. Because whatever shoots out from under that lawnmower could shoot 100 feet and kill somebody that's out working in the flower bed in that yard. Because the lawnmower is not made to protect anybody else in the yard. Just the person behind the lawnmower is the only person it's made to protect. We would see tons of those in the summer, tons of them. And they would come in dead. Kids with wires in their chest all the time, all the time. Blunt trauma is exactly it. It would hit with such force that the force would go through the skin to the organ below and damage the organ below. So it could be a motor vehicle accident, you know, like the steering wheel or the side of the door coming in and getting you, or it could be where you fell. And of course you hit the ground and boom, 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 boom. It just caused a lot of energy, kinetic energy that would get you, or a baseball bat or a 2x4 hitting you, or, you know, a helmet. I'm so sorry. I apologize. Helmet to helmet or something like that. Or, you know, or just a helmet to your ribs or whatever, your helmet to the ground or whatever it happened to be. So those, but there's no penetrating inside into the body. Actually, the more difficult one to treat is the blunt trauma because it's more diffuse. It's more widespread. A penetrating trauma, we can almost go in with a hemostat and say, oh, this is where the knife went, boom, clamp it off and stop the bleeding. You can stick your finger in the dike and stop the leak. Penetrating traumas are much easier to treat than blunt traumas are. And we do treat them very differently. And so mechanism of injury, mechanism of what's going on is very important. Okay. So when we're talking about traumas, we've got to figure out if we have all these traumas. Trauma is a very broad term. Some are very emergent and some are very non-urgent. So we have to figure out what is urgent and what is not urgent. It's very important. So we have to prioritize. Probably in the trauma situation is where we really start to look at prioritization. Now, there's prioritization across every patient, and we use the same priorities across every patient. But this is where you're really going to apply priorities, where you're going to be tested very highly on priorities, all right? So we're really going to look at this. So every time, regardless if it's trauma, regardless if it's endocrine, regardless if it's respiratory, you are going to always use ABCs. Your highest is Maslow's hierarchy of needs, and it's always ABCs. So your priority and your highest priority is A, B, C, D. A stands for airway. B stands for breathing. C stands for circulation, and D stands for disability. Okay, now disability means impending herniation of the brain, bad head situations, like bad head trauma. All right, so airway is first. Airway, I may have said this when I did respiratory, but I'm going to say it again because it's so important. Airway is a sound. Okay. So if the patient is able to talk or make a sound, their airway is patent. So if they're crying, they're moaning, they're babbling, they're talking, or you hear breath sounds. You hear things coming out of their mouth, okay? If they have abnormal sounds, then there's an airway problem. So wheezing, stridor, crackles, rails, rhonchi, grunting, loud, snoring. You're hearing a sound, but there's something wrong with the airway. They still have an airway, but there's something wrong with it. So typically, those kind of sounds are, those adventitious sounds are, there's something wrong with the airway. They still have an airway, but there's something wrong with it. So sounds are usually associated with airway. But if you hear a sound, at least they have an airway. All right. If there's something in the airway, there's a problem with the airway. Blood, vomit, teeth, grass, bananas. I don't know, a McDonald's hamburger they were eating when they wrecked their car, and you've got other stuff stuck in their mouth. A lot of saliva, thick green mucus. I don't know. If you suspect there's something in their mouth, with trauma, we see a lot of blood, we see a lot of teeth, we see vomit, we see where there's dirt and grass, where their face has just been shoved down into the ground, or they've been thrown from the car and they've slid along the ground and they come in with dirt all in their mouth. I would suspect possibly something going on with their airway. Enough for me to go over and look and see if there is something wrong with their airway. Okay. Along with airway goes C-spine with the trauma patient. Now, look at me. Everybody put your pencils down and look at me, because if you don't, you're going to miss the test question. You're going to miss, half of you are going to miss it anyway, because you're not paying attention to me. When I say airway and C-spine go together, I mean one thing and one thing only. You are to immobilize the C-spine. You are to do nothing else but immobilize it. And you learn this with your spinal cord. It could be your hands. It could be a cervical collar of some kind, but you're not going to go moving their neck around. A trauma patient that has a car accident, or they have something around their head, or they fell from a building or something, you are to immobilize their C-spine at the same time that you are checking their airway. That's all I mean by C-spine. You are to immobilize their C-spine.
Miss Janie, I have a question.
Sure.
So if we're ventilating them, you know how we're supposed to do like the head tilt, chin lift, are we still able to do that because that's moving their neck?
Well, what do you think? Just
no. I would say no.
The answer to that is no. You're exactly right. Head tilt, chin lift typically is an absolute no for most trauma victims. Now, if I told you that this patient slipped off of a one-step ladder and fell flat on their butt and cracked their pelvis, chances are they didn't hurt their neck. And then they're old and they got in trouble late, then maybe that would be okay. If it was something like, or they had just a fractured femur from being old or something. But if they are a major trauma victim, like from a car accident, then we've got to protect their neck. So most of the time, a head tilt chin lift is an absolute no. Okay. So Abigail, since you had the gumptions to open your mouth.
Oh boy.
What's another way to open their airway? I've got a slide about this later. What's another way?
Well, I mean, this is technically cheating because Danielle said something in the chat, but she did say, thank you to her for giving the answer.
Well, tell me what it was.
Said, the jaw thrust.
Right. I can do a jaw thrust without, I'm usually above the patient, throwing it this way. I can do a jaw thrust without moving their neck. Absolutely. Absolutely. But I can't do this. I just made them a quad. If they had a broken neck, I just made them a quad.
Right.
Can't do that. Or tetraplegic. That's the new term. I'm old. I'd still call them a quad. A tetraplegic. Okay. So no, you cannot do a head tilt chin lift. Okay. Breathing. How do you know airway from breathing? Did I already do this when I did respiratory? No? You want me to do it again? Doesn't matter. Breathing. How do you know airway from breathing? Airway is sounds. Airway is stuff in the airway. Breathing. Rate. What is the rate? If I give you a rate, it's a breathing problem, unless it's normal. 12 to 20 is normal. If I call it bradypnea, if I call it tachypnea, if I call it apnea, it's a breathing problem. They're not breathing. They're breathing fast. They're breathing slow. They're breathing. If I tell you work of breathing, they're breathing shallow. They're breathing deep and fast. That's breathing. That's not airway. That's breathing. If they have asynchronous chest, that's not an airway. That's breathing. One going up and down. If they have breathing, retractions, that's a breathing problem. It's not airway. If they have work of breathing, nasal flaring, head bobbing, those are breathing issues. So work of breathing, things about how hard they're working to breathe, that is a breathing issue. So rates and how they're breathing is a breathing issue. That's how you differentiate airway and breathing. Oh, I slapped myself. Okay. And then C is circulation. And we're going to talk about circulation in just a minute. So we're looking at blood flow. We're looking at heart pumping. Okay. And then D is impending herniation of the brain. Those are our highest priority, A, B, C, and D. Lower priorities are things that probably won't kill you. It doesn't mean something's not wrong. It just means it probably won't kill you. So other neurological injuries, like maybe a C-spine injury that's not, no, excuse me, I said that wrong. A spinal cord injury that's not in the cervical spine. So maybe something like in the lumbar area or in the thoracic area. I still want to be careful. I still won't sit them up. I still will keep them in alignment. But it's not going to kill them. It's not going to kill them. Maybe abdominal trauma, but they're not showing signs of hemorrhage. Maybe something cardiac, but they're not showing tamponade. They're not showing something that's going to kill them. Maybe they broke their leg, but it's not going to kill them. Maybe they have some big old bruises. Maybe they have broken elbows. Maybe they have some big old problems, but things that aren't going to kill them. I had a friend that was in a pretty bad car accident. And when he woke up and they got him up for the first time, he had a broken ankle. And the family said, can you believe he was there for a whole week? And when they got him up, his ankle was broken and nobody knew it. I said, the man was in a coma and being intubated. Can I believe his ankle was broken? Yes, I can believe his ankle was broken because his ankle was not his priority. Maybe they could have caught it, but until he got up and said, oh, my ankle hurts, I can believe his ankle was broken. Yes. Aren't you glad that they caught his head and his respiratory status and they got him out of a coma and he was alert and knew enough to say, Dad, my ankle hurts. Oh, I didn't think about it like that. Yeah, I can believe his ankle was broken. Now, if it had been broken in half and turned backwards, they probably would have seen it. But to have a little bone broken when he's black and blue all over, yeah, I can believe they missed it. Sure. Absolutely. Okay, so what do? How do we not miss things? How does this go? We use a systematic approach for the initial assessment. We do a trauma assessment. Now, the purpose of this is to recognize a problem, fix it. I'm not talking about definitive treatment. Like if you notice something's broke, you don't fix it right then. But if there's an airway problem, you've got to address the airway or they're going to die. If it's a breathing problem, you've got to address it or they will die. If it's a circulatory problem, you got to address it or they will die. I'm not saying we've got to fix that broken ankle right now, but we would at least splint it to prevent further injury. But it's to recognize life-threatening situations and prioritize and determine their care and hopefully recognize all injuries. But you got to do a systematic assessment. Now, this assessment was developed by the American College of Surgeons. And this is one of the things you do to be a level trauma center. And the more you do, the higher level you are, like a level 1, which is the highest level you can be. So they have a level 3, a level 2, and a level 1 trauma centers. And it kind of identifies what you're able to give your patients. And Caroline's Medical Center is a level 1 trauma center, the highest trauma center you can be. Okay. And so they use the same trauma assessment on every single patient. Every single patient gets the exact same assessment. Now, those of you that might end up in the ED in your preceptorship, or some of you that maybe have worked in the ED, may not quite recognize this as done because we have great staffing. So they may have one person doing A, one person doing B, one person doing C, and one person doing D. But if they only had one doctor on, the doctor would do this assessment in the order that we're getting ready to do this, okay? And on the test and on NCLEX, you are by yourself. You are the one that has to do this. So don't sit there and say, well, the tech would have done that. Not unless I tell you there's a tech, they don't do that. Well, respiratory would have done that. Not unless I tell you there's a respiratory therapist there, would respiratory have done that. All right. So you are by yourself unless I tell you there's somebody else there. So what is this primary survey? Well, we use a little alphabet. Okay. And it goes A, B, C, D, E, F, G, H, I. Now, this only goes to G on here right now, but we're going to get to it. A, B, C, D, E, F, G, H, I. And I used to say, students don't know their alphabet. How come they don't know their alphabet? They should know their alphabet. They're in college. They should know their alphabet. But then I realized you don't know what is in A, what is in B, what is in C. So you need to know what each one of these are. So when you're prioritizing, you have to start with A. If there's a problem with A, you have to assess them. Is there a problem with A? And if there is, you have to do something about it. If there's not a problem with A, then you move to B. Assess them. If there's a problem, you do something about it. If there's not a problem with B, then you go to C. If there's a problem with C, you assess for it and you do something about it. Not everybody has a problem with A, a problem with B, a problem with C. Okay, so we're going to go A, B, C, D, E, F, G, H, I. Now, if you've got a critical care book at home and you really like to read the critical care book, or you've got a different book than Lewis, because the information is pretty much the same, this might be something that's a little bit different. Different people, different books put different things in E, F, and G. I will tell you that on the test, that will not mess you up. Okay, I've made sure that the test is worded in such a way that E, F, and G will not mess you up, because I know there's different books that put different things in different categories. Like, for example, some people put environmental controls, they call them Fahrenheit, and they put it under F instead of E. But I would ask the question in a way that it wouldn't matter if you had it under E or if you had it under F. It wouldn't make a difference, because I don't think that would be real fair to you, that there's different resources that give you different answers. So I wouldn't do that to you. All right, so let's get started. A stands for airway and C-spine. When I say C-spine, I mean immobilization of the C-spine. You're going to look for any air movement and any changes of their sounds. So if they're talking, they got an airway. If they're moaning, they got an airway. If they're babbling, if they're crying. But if they have an adventitious breath sound, there is an airway problem. And I just named those a minute ago. So you would want to position them by immobilizing their airway, their C-spine, immobilizing their C-spine and opening their airway. And we would use a jaw thrust, because you cannot use a head tilt chin lift, because that would not be immobilizing their C-spine. You cannot sit them up, because then you're bending their lower back and you could make a para out of them. So you cannot sit them up. If they are vomiting or they have large amounts of blood bubbling out of their mouth, you can take the whole backboard and turn them on their side, keeping their C-spine in alignment, and you can help to clear their airway that way, but you cannot bend their neck or bend their back. You can suction with a Yankauer suction and try to clear their airway that way, of vomit, blood, teeth, whatever it happens to be there. Get the obstructions out of there. We usually use those Yankauer suctions, those hard suctions, to clear that out of there. Unless the patient is very, very, very with it, do not put your fingers in a patient's mouth. They might bite you. But I've had patients that are very with it, that I can see that there's teeth laying in there, and I'll say, don't you bite me. I'm going to reach in here and pull this big clog of mud out of your mouth. Don't you bite me. And I'll reach in and get that big clog of dirt or that banana and just squirt it out of there, because they were eating a banana when they wrecked and they ran that banana down their throat. So I have, but as a whole, if I can't do it, I will, but only if they're with it. If they're unconscious, I will not put my fingers in an unconscious patient's mouth, because they can reach down and bite you. But I will if they know what I'm doing. But you got to get those obstructions out of there, okay? So with trauma, blood and teeth are very common. You look, they don't have teeth up here, you're concerned, where are those teeth? You know, where are those teeth? Are they in the back of their throat? Don't know. Okay. So you might suction them. If they're stridor, if they're having difficulty breathing, someone, not you, but you may be setting up to help to intubate this patient. We may need to intubate this patient. They may need to do a cricotiotomy on them. But they may need to do a tracheostomy on them. I don't know. But we've got to maybe intubate. We need to secure the airway in other ways. But airway and immobilization of the C-spine is a highest priority for this patient. If I go over there, they're talking, they're crying. They may have blood, but I want my mommy. Oh, their airway's fine. I'm on to number 2. Okay, number 2 is breathing. Okay, There's lots of reasons, especially chest trauma can result in this. We're going to talk about chest trauma probably tomorrow or Friday. But I want to look at their rate. Is it fast? Is it slow? Is it absent? I want to look at their chest. Is it equal, or is one side going up more than the other? Are they in dyspnea? Are they struggling to breathe? Are they really complaining of shortness of breath and air hunger? Are they trying to splint? Are they trying to hold their chest because it hurts to take a breath? Is their inspiratory and expiratory cycle not 2 to 1? You exhale twice as long as you inhale. That is a normal inspiratory and expiratory cycle. If it's even, then it's not normal. And the more tachypnic you get, the more even your inspiratory and expiratory cycles get. And so you should have a 2 to 1 inspiratory and expiratory cycle. Are they really shallow because it hurts to take a breath? They're not exhaling their CO2 with like rib fractures, for example. I want a good depth of respirations and a good exhalation of CO2. I want to look at their I want to look at their jugular veins. Are they distended or not? I showed you some JVDs before. I want to look at them. I want to look at their trach. Is their trach in midline or not? When you're checking for midline, you want to check at the sternal notch. Is it right in the middle of their sternal notch, or do you feel their trach over at the side? Don't be checking up here. In order for this to be over here, it had to move slowly and it had to take a long time. This is the first place it's going to move. To check it up here is really a late time, and the patient's in severe distress. We're going to talk about increased JVD, and we're going to talk about tracheal deviation when we get to chest trauma. But this is all part of breathing. Rate, depth, JVD, and work of breathing falls within breathing. Okay? And we're going to talk about how to fix it. And so what would we do? Well, what's causing it? If they're struggling to breathe, then we might need to breathe for them. They've already had their airway, but maybe they need a bag valve mask because they're not able to breathe. They're apneic. Maybe they're hypoxic. Let's get a pulse ox on them, maybe. Let's put some oxygen on them. Oxygen falls within breathing. Get some high flow oxygen on this person. Again, we can't sit them up, but maybe oxygen will help. Maybe we can turn them on their side. Maybe that would help them breathe a little bit. Turn their backboard up and stick some blankets or some sheets under it so that they're sort of just turned up a little bit. Maybe they're just a little orthopnic and orthopnic's the right word, but they just can't stay supine. They're just somebody that's maybe a little older. I would have trouble laying on my back. You know, when I go for a massage, I say, I can't lay flat for a really long time. Can you at least put a pillow under my head? I can't put a pillow under a trauma patient's head, but I could put something under the backboard and raise the backboard up a little bit at the head, and probably I would be fine with that. So what can you maybe do to help them breathe better? Oxygen tends to be the answer, or treat the underlying cause, which we haven't gotten to yet. All right, circulation. What are you going to do for that? Assess their circulatory status. Again, how do you do that? Well, check their pulse. Is it fast? Is it slow? Is it absent? Is it regular? Is it irregular? I don't care what its rate is. I don't care. Is it 72 or is it 82? I don't care. I have enough experience that if I put my hand on your pulse, I can tell if it's fast or if it's slow. If I say it's normal, I'm fine. If I go, wow, she's fast, I know that's a problem. Wow, she's slow, I know that's a problem. It doesn't matter the exact number. I need to look at it, okay? So I know rate, fast, slow, or absent, okay? I need to look at other things. I need to look at capillary refill. Best way is to lift the extremity above the level of the heart is the best way, and check wherever. If you can check the nail beds, good. I have nail polish on. You can't check mine with nail polish on. So what do? Do you just say, oh, well, too bad, so sad, they got nail polish on? No, you can check capillary refill anywhere on the patient's body. So what I do is I just grab right here and I just squeeze right here and it blanches and it'll come right back. That's the best place to do. Just grab right here and it'll blanch and come right back. And it should come back within 3 seconds. Cap refill is end organ perfusion. End organ perfusion is the other name for cap refill. It is a perfusion problem. It means it is a circulatory problem. It is not a breathing problem. Putting oxygen on a patient with a delayed capillary refill of greater than 3 seconds does nothing. It is not a breathing problem. It is a circulatory problem. Cap refill is circulatory.
Janie, what did you say to like raise the extremity above the heart to check it?
The correct way to do a cap refill is to have the patient lying flat, raise the extremity above the level of the heart, and compress. Now, in the ED at triage, when I check in 250 to 350 people a shift, do I lay every single patient down and do that? No. And I have to document cap refill. But let's say I've got somebody in the ED, I'm the trauma nurse, and I know they have a splenic hematoma. We're not taking them straight to the OR. We're going to watch all their stuff, their vital signs, everything about them. And one of the things I'm watching is their cap refill. And if I'm going to use cap refill as a determining factor, then I would want to do this person absolutely correctly. He or she would be laying down, and every hour when I did their cap refill, I would raise it. I would do it the same way every time. I'd raise it up and check it. I'd raise it up and check it. That way I'm using the same determining procedure, this exact same way every time. And that's really the correct way. But again, if I had to lay down 350 patients at triage, hell, we'd never get through triage. And, I don't need to on those patients. I don't suspect anything on those patients. But if you're going to use it for true determining factors, then you want to do it. The best way is to raise it above the level of the heart. That's the best way to do it. Okay. All right. So you're going to assess circulatory status. And we're going to talk about this a little bit again more. The correct treatment for your circulatory status is we're going to establish 2 large bore IVs. 18 gauge and larger is considered a large bore IV on an adult. So we're not going to start little 20s or anything. We're going to start 18, 16s, 14s, or a central line. If doc will put in a central line. But nurses can put in 18s, 16s, or 14s, okay? So we're going to put in roofing nails in these people. I'll tell you, 14 looks like a roofing nail. It really does. Huge IVs in these people. So we're going to establish 2 large bore IVs in these people. And we're going to give them fluid resuscitation. Now, fluid resuscitation is done with an isotonic solution only. Isotonic solution only. They are down, they are in fluid volume deficit in their circulating blood volume. And we're going to talk more about this. Therefore, I want to put fluid into their circulating blood volume. And I want to put it there and I want it to stay there. Because what's going to happen is if their circulating blood volume doesn't stay up, their cardiac output will drop and they will develop VFib and they will die. So if they're still dropping blood into their fractured pelvis, every time it circulates, it's dropping into the fractured pelvis. If I'm not keeping the volume up, the patient's going to die. I don't care if their tissues are dry. I don't care. I'm sorry your cap refill is bad. I'm sorry. I'm so sorry you're tenting. I am so sorry. But tenting does not kill you. Your decreased blood pressure is going to kill you. So fluid resuscitation, 100% of the time, is done with an isotonic solution. There are only 2 isotonic solutions. One is lactated ringers. The other one is normal saline. Lynn Wilson, you're always the first one on. What is the percentage of normal saline?
9%,
No,
or sorry, 0.9%.
0.9%. 0.9%. So we could call it we're gonna give them back isotonic solution. We could call them, we're gonna give them back normal saline, or we could say we're giving them back 0.9% saline, or we're giving them back lactated ringers. We're basically saying the same thing in every time we say those words. Those are the only isotonic solutions. Now, when we give isotonic solutions, when we give back IV fluids, which are crystalloids, when we give back regular IV fluids, it's at a 3-to-1 replacement rule. So if we think they lost 500 mLs or cc's of blood, we will replace it back with 1,500, 500 times 3, 1,500 cc's of IV fluids, plain old clear IV fluids, isotonic IV fluids. It's a 3-to-1 rule. And sometimes it's an estimate. How much you think they lost, medic, on the ground? Wow, they lost about 500. They lost about 800. Okay, 800 times 3, we're going to give them back 2,400. Sometimes in the OR, it's actually measured in a little canister, and we know exactly how much they lost. If we go to blood, if we go back and we replace them with colloids, colloids are your most of the time blood products. It can also be certain medicines like albumin, which Jane talked about with liver, which is a volume expander. It sucks stuff to it. Heptastarch is another colloid. Albumin and heptastarch are the two most common, and blood is the most common colloids. It is a 1-to-1. So if they lost 500 cc's of blood, we give them back 500 cc's of blood. Okay? That's how we do a circulation. Assess it, and then we give them back fluids, whether it's crystalloids or whether it's colloids. And then just to finish off D, which is the highest priorities, A, B, C, and D. D stands for disability, which is neuro, impending herniation of the brain, bad head trauma. Okay? And typically we'll do something really quick like what we use is AVPU. You can do a Glasgow coma score, just the same. We've already talked about Glasgow comas. Glasgow coma scores. If it's 8 or less, typically they'll be in a coma. But most of the time we just use AVPU. Now AVPU is just their alertness, okay? And so A is their alert. V is they only respond to verbal stimuli. You have to talk to them in order to get them to respond to you. P is painful. You have to shake them real hard, or you have to really stimulate them to get them to respond to you. And U is unresponsive. So sometimes they're not into could they squeeze your hands or not. It's just what is their level of consciousness more than anything, without a score number. So some places, depending on what's going on and how quick you need it, it's just are they alert or not, or they only respond to pain, or they only respond to voice, or they don't respond at all. So that's what AVPU is: alert, verbal response only, painful response only, or unresponsive. So that's what AVPU is. All right, y'all, it's 1 o'clock. I will see y'all back here at 1:10, and we're going to come back and talk about E. I'll see y'all at 1:10.
Hey, Jamie.
Yes.
So when you were talking about adventitious red sounds for A, does that include like lung sounds? So the lung sounds wouldn't be associated with B?
Adventitious lung sounds mean abnormal. Adventitious is the word for abnormal.
Uh-huh.
They call them adventitious.
Right. I just wasn't sure if you meant just like from what you can audibly hear, if it also meant the lung sound assessment.
Typically, it's with the stethoscope. Doesn't have to be with your ears. It's with the stethoscope. Yes.
Okay. And why is it that JVD would be a B problem and not a C problem?
Well, we haven't gotten to it yet.
Oh, okay.
But when we talk about chest trauma and we talk about a tension pneumothorax, you get JVD.
Mm-hmm.
When Jane talks about a cardiac tamponade, you get JVD, but then it will be a C problem. So what is the mechanism of action? When it's a trauma patient with JVD, you'll hear me say this again. When it's a trauma patient with JVD, then we're thinking it's a tension pneumothorax. When it's a post-op cardiac patient, patients had open heart surgery with JVD, it's not a breathing problem. It is a cardiac problem. They have cardiac tamponade. So what was wrong with your patient to start out with? You can't just have this black and white answer. Nursing students want a nice little black and white answer. Why can't you just give us a yes or no answer? It's healthcare. It's people. There is no black and white answers all the time. What's wrong? Tell me what's wrong with your patient, and I'll tell you what it is.
Okay.
They were in a car accident. Oh, hell, it's tension pneumothorax. They're on PEEP. Oh, it's a tension pneumothorax. It's a breathing thing. Well, they had open heart surgery. Oh, it's cardiac tamponade. Well, they had pericarditis. Oh, it's cardiac tamponade.
Okay.
What's the causative agent?
Okay, thank you.
Okay. Anybody else? I'll come back in just a second. I'm just going to go to the restroom, but I'll be back. And if y'all have questions, I don't mind answering them during break. I'm just going to run to the restroom really, 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 really quick. I'll mute so you can hear me.
Hey, Janie.
Yes.
When you said that, like, they're talking, you assume they have an airway. If you're like, if you can see them breathing and you can hear them breathing and like see their chest moving, do you assume they have an airway?
As long as it's not stridor.
Okay.
I mean, if they're going, maybe not. I mean, it's not an effective airway.
Okay. Thank you.
But yeah, if they're talking or they're crying or stridor makes me gag. When I do stridor. But stridor just means that they're pretty much occluded and moving very little. But yeah, anything. I mean, even with wheezing, they have an airway, but it may not be effective. But we might have to do something. But wheezing, they still have an airway. But stridor is right here, and they may have just a tiny, tiny little bit of airway, but they're not going to have an airway for long.
Okay.
What time is it? Oh, it's time to start. I'm sorry. 16. Okay. All right. So it's 110. So A, B, C, and D is your priority. The rest of it, and that is considered in your, well, never mind. That's your priority. Then you get to E. E is expose and environmental control. Now, expose and environmental control means expose the patient. Cut their clothes off, because you're not going to be able to sit them up and take their clothes off. If there are significant enough trauma, then we're going to cut their clothes off of them. Some patients get upset over this. So, what do they really need? But typically they will have their clothes cut off of them. And then after you expose them, you will then need to warm them back up. And that's what environmental controls mean, is to warm them back up. You can put warm blankets on them. Some units have heaters. Some of them have just like that's in the NICU, those overbed warmers, but they sit over a big stretcher for adults. But those are really hot for the employees that are all dressed out. So typically we just use warm blankets, but you don't want to just leave the patient exposed in the cold air, because they'll vasoconstrict, and that's not a really good thing for them to do. So typically, as soon as you expose them, you need to put a nice warm blanket over them. F is facilitates adjuncts, and think about the family at this point. This is when you're now going to get a full set of vital signs. Now I want to know, is their heart rate 62 or is it 82? I now want a blood pressure. At this point, I really haven't had a blood pressure. I now want a full set of vital signs, including a temperature. So no one's really given me a vital signs at this point. I've only known if it's fast, slow, or regular. What's their respiratory pattern been? But now we really want a full set of vital signs and a pulse ox. I will tell you, and I think I've said this before, teaching new nurses that getting vital signs and hooking them up to the monitor is not the first thing you do for patients. Taking care of your patients are the first things that you do. And it's really hard to teach people not to do that, I will tell you. So this is pretty far down the list on what we need to do. We also need to think, should families be available to be in the rooms for these resuscitations? Most literature will tell you yes. You should let family be present. Along with that, though, somebody has to be available to be next to the family and tell them what is going on. You will find that lawsuits will decrease if families see what is happening. Codes will not go on as long. They will decrease resuscitation efforts on people that are dead. That when they understand how much work went into trying to save their family member and it was not successful. You keep them out in the waiting room. They're waiting. Their family member dies. They come in. The room has all been cleaned. The patient's all cleaned up. Everything's been pulled. You're sitting there. You have their head up and you have the nice clean sheets on them. And they're sitting there like this. And they say, you all didn't work very hard on them, did you? And you all know that we did work hard on them. But the family doesn't see that. I will tell you, when we let families come in, how often, especially when the patient is in an arrest situation, how often they will say, that's enough. That is enough. Don't do that. Don't do that anymore. And they won't let the family stop something when there's still a chance of saving the person's life. Let me assure you, they would not let that if they could really save that person's life. But it's really, if you'll let the family be in there, you'd be surprised at how much the efforts will stop earlier if you will let them be there for situations there's just not a chance these people are going to live. And then we're going to go on to resuscitation adjuncts, things that really aren't going to be part of the resuscitation effort, but that we need them. For example, lab tests. There's usually a preset amount of labs. So, it's going to be your typical CBC and your BMPs and your CMPs. If it's a woman of childbearing age, we're going to get a pregnancy test. We're going to get type and crosses. We're going to get drug screens, alcohol tests, everything we need. There's going to be a specific set of lab values that need to be, or labs that need to be done on all the patients. We'll get an EKG. It does say NG tube here, but we will put down an oral gastric tube. Remember, we don't typically put down NG tubes on trauma patients because we just don't know what's happened to the face yet. So typically we will put down an NG tube to decompress the stomach and to see if there's any frank blood into the stomach. Pain management. If the patient, in the appropriate situation, we want to get pain management if it's appropriate for the patient, and the emotional support again for any family at this point. But we're all the way down to G at this point. So we're getting pretty far down in the A, B, C, D, E, F, G, H, I. Okay, so this was all primary survey. Primary survey are things that are considered life-threatening to very important. Going with A, B, C, D is the true life-threatening part. E, F, and G are the things that we have to do, okay? Then we're going to go to the secondary survey. Secondary survey is for more thorough exam to hopefully identify those other injuries that might get missed, like the guy whose ankle might get missed. And it is H and I. We go down through H and I. Now, H has two things. It has history and head-to-toe assessment. And so what is the history? We use AMPLE as the mnemonic for history. We want to know, do we know if this patient has any allergies? And MEDIC is the one that can usually tell us this because they try to get this information. And you can see at the very top, it says trauma survey after the initial assessment's taken place. This is when we want to know this stuff. Do we know if they have any allergies? Do we know what kind of medications this person's on? So, if they say, well, yeah, he takes metformin. Well, we know they're a type 2 diabetic. Or they take AZT. We know they have AIDS. Or what kind of medications, or they're on lisinopril. Oh, they have hypertension. What type of medications does this person take? Okay. What's their past medical history? And so that may help us in trying to decide what we're going to do with this patient. Oh, they have terminal cancer. Does that make a difference in what we do? Or stage 4 cancer, does that make a difference in our resuscitation efforts? It might. It might not, but it might. I don't know. We got to know, do we know anything about their past medical history? L, last meal / last tetanus shot. We're going to talk about tetanus shots when we get to immune, but tetanus is really important in the emergency department because very few areas outside the emergency department really care about tetanus shots. So when was the last time they ate? Because we're probably going to take them to the operating room. And when was their last tetanus shot? So L is usually last meal / last tetanus shot. And what were the events surrounding the injury? Were they the driver in the car or were they in the back seat? We expect 2 entirely different kinds of injuries based upon where you sat in the car. Chest trauma if you're the driver, low spinal cord injuries if you're in the back seat. Were you stabbed by a man or were you stabbed by a woman? You wouldn't think that would make any difference. It makes a huge amounts of difference. Men almost always stab in an upward motion. Women almost always stab in a downward motion. You know, we come chasing you with a knife like this. Men walk up to you and stab you like this. Makes a huge difference. Do you know what kind of gun you were rifle or what you were shot with? And I don't know much about rifles, but all the ER docs do. And I'm making this up, so don't write this down, okay? Because I don't know much about it. But I know, and I think it's a 22, but I wouldn't swear to it. Like a 22 rifle. And some of you that know rifles are going, I ain't right, JD. But I think it's a 22 that will not break bone. So if they say they were shot with a 22, I already know, and you're shot in the thigh, I already know it didn't break your femur because a 22 cannot break a bone. You know, if I know it's a shotgun, it has 1,000 little pellets, and I'm worried about these pellets all over the place. It's not just one bullet that goes in. So do we know what kind of gun they were shot with? I used to say 747, but that's an airplane. There's some kind of Magnum or something that has some names under it. But I know a 747 is an airplane. It's not a gun. So, but you know, what do we know what it was? Type thing. I'm not good on guns. I will let you know. There's not a gun in my house, and I hope there never will be a gun in my house. But some of you are into guns, and that's good for you. Okay, so let me go back. I didn't finish my thing. So that was what history is. And then we do a head to toe assessment. The head to toe, they start at the head. They start feeling. Do I feel anything up there? Did I bring my hand away and it had blood on it? Or I feel a hematoma up here? Do I see a battle sign? What do I see? What do I see? Do I see any otorrhea coming out of their ears? What do I see? Start working down. They start moving all the joints. You know what? I feel some crepitus here. This joint doesn't want to work real well. Let's make sure we x-ray that right shoulder. Let's move. Oh, you know what? I also feel it in this elbow. Let's make sure. Let's just do the whole arm series. They'll come by and they'll do every single joint. They start to x-ray. They start feeling everything and they just look down all the way down. That's when we've got them stripped. We're going to look for any bruising. We're going to look for anything that doesn't quite look right. Okay. They're going to feel everything, palpate everything, look, listen, and then palpate just in the order you all were taught. They're going to do everything all the way down to their feet. And then they're going to inspect the back. They're going to log roll this person. They've probably been taken off the backboard by now because we found that we need to get them off the backboards as soon as possible because backboards by evidence base has been shown to contribute to decubiti. And so we want to get them off the backboards as soon as possible. The first decubiti from backboards is occipital. So typically we will get them off the backboards very quickly.
Hey, Miss
But now
Janie.
yes.
Janie, I was just going to say something. I work for Medic, and we will take them off the backboard once we get them on the stretcher. Like, we don't even leave them on the backboard anymore. We used to, but not now.
Oh, to take them into the hospital?
Yeah, we'll
Oh,
immobilize them.
that's
Like,
great.
we'll lay them flat on the stretcher, but we won't use the backboard.
How do you transfer them over?
Well, we'll like you.
Oh, you bring them into the hospital on the backboard, but then you get them right off. Is that what you're saying?
No, you put them on the stretcher with the backboard. You like log roll them onto the stretcher
At the hospital or in the truck?
in the truck.
Oh, so they're not even going in the hospital on a backboard.
Correct.
How do you get them off the truck stretcher onto the hospital stretcher? Just a lot of people?
Yeah, you just have a lot of people.
Yeah.
Bradley, don't they still put them on a C collar? We're just not using backboard.
Yes.
Oh, they'll
Yeah.
have a seat collar on. Okay, so they're not even using a backboard.
Mm-mm. Very occasionally you'll see them. If somebody's got like something where it may be like a major back trauma or something, they'll come in with one, but not usually.
We were all just on the sheets and we move as one, just the sheet pretty much.
Okay, that's new for me. That's new for me. Okay, all right. Okay, but I know they were getting them off the backboard as soon as they got them in there, as fast as they could because of the decubiti that they were forming. Yes, interesting. And then we're going to inspect their back because people are allowed to get injured on their back. Okay, so we want to look at their back, and when they're looking at their back, they're going to look at 3 things on men and 2 things on women. Okay. So they're going to run they want to look at their back, and then they're going to run their fingers down their spinal cord. And if the patient is with it, they're going to say, tell me if I hit a sore spot, somewhere that hurts. This is point tenderness. And if you remember, point tenderness indicates a break in the bone. So if you're running down their spinal column and they go, oh, right there, that could indicate a fractured cervical bone or a spinal bone. Okay. So we're running our fingers down to make sure that the spine is even where it's supposed to be. If they're unconscious, it should just come smooth. If it's like sinking in or stuck out, we call that a step off. And if it's sticking up one way or the other, then we would worry about that. Did the bone sort of displace itself? So we're running our fingers down their spine to see that. The next thing they're going to do is they're going to stick their finger up their bottom, right? And they're going to do that for everybody. And so when they stick their finger up their bottom, if they don't have a spinal cord trauma, they'll have an anal sphincter. And so they stick their finger up their bottom and their anal sphincter will tighten around the person's finger that puts their finger up their bottom. If there's not any kind of tone, if they have no rectal tone, or it's really weak, that could indicate a spinal cord injury. So putting their finger up is routine. You're going to get a rectal. While the finger is up there, if you're a man, it's really this direction. They're going to put their finger up there and they're going to feel for the prostate. Now, they're not trying to see if you have any lumps, bumps, or whatever. Right there should be your prostate exam if you're a man. If they reach there, the prostate's not there, it's too high or too low, it's almost impossible to move the prostate exam without tearing the urethra. And so typically they'll run their finger down there and they'll say, okay, prostate's in place. That's when they want the Foley put in, if it's a man. But typically they don't want the Foley put in until after they've done a rectal exam on a man because they want to know that the prostate is right where it's supposed to be. If the prostate's been torn, the prostate's moved and the urethra's torn, there will be blood at the meatus of the man. And you don't put a Foley in a man that has blood at their meatus because that can mean a urethral injury. And then you're trying to stick a tube down a tract that's been torn. And that's not good. Women have a urethra that's only a half of an inch long. So it doesn't typically get torn. Men, their urethras of varying sizes. Let's just put it that way. So their urethra can get torn very easily. And then the third thing is when they pull their finger out, they're looking for any blood on their finger. So that could indicate a bowel injury if there's blood on their finger. So that you're going to get a rectal when you are major trauma, you're going to get a rectal exam. And then, of course, they're just looking for bruises, like flank bruises or anything that's obvious. We've had people that have car wrecks and they'll turn them over and there's a gunshot wound in their back. And that was why they wrecked, because they got shot. So you're allowed to get injured on your back. All right? Okay. So A very specific kind of trauma is abdominal trauma. So now we're talking about just the abdomen, all right? And abdominal trauma is diagnosed by pain, rigidity, guarding. In other words, don't touch it, it hurts. And they will have what's called rebound tenderness. Now, rebound tenderness it hurts more when you let it go than when you push it in. Rebound tenderness indicates a ruptured viscera. Viscera is an internal organ. So if you rupture an internal organ, then you will have rebound tenderness. And you get this more with blunt trauma. So how do I know if you popped your stomach? How do I know if you popped your uterus? How do I know if you popped your bowel? How do I know? It's not like, if you have a gunshot wound, I know something got popped in there. If you got stabbed, I know it's popped. But how do I know if you popped your gut? How do I know that? Well, you will know it by rebound tenderness. And so you push in on their belly and they go, oh, and you let it go and they go, oh. And I say, well, what hurts more, when I push in or when I let go? And they will say, when you let go. Rebound tenderness means something is ruptured in there, and whatever was inside of the organ is now out into the cavity, and it's irritating the lining of your viscera, of your internal cavity. It could be blood, which is very common, probably the most common. But if it was your bowel, it could be poop. If it's your stomach, it could be acid, gastric acid, or it could be corn, or your ham sandwich you just ate, or alcohol. If it's your pancreas, it could be amylase and lipase. So it could be whatever, your liver, you get a lot of bile could be released in there. It could be whatever that you popped could be in there. And that could be what's irritating it. All right. So you're checking for rebound tenderness. And I have to tell you, I was always sneaky when I was in triage. And I would put the patient's arm across, like this wasn't for major traumas, this were other people, because people come in and their seatbelt, they hurt where their seatbelt was. And so when medic would have them out in the hallway, I would take their arm and I would take their pulse. Wrong side of their arm, but I would take their pulse and I would set their arm on their belly. And as I would act like, or I would be, but as I act like I was taking their pulse, I would push down on their arm with my hand. And then I would sort of push down and then I'd let it go. And I wanted to see what their reaction was. Because when I would not be taking their pulse and then I would push on their belly, they'd go, oh. But when I was taking their pulse, they wouldn't tell me that their belly hurt. Because they didn't want to have to go to the waiting room, or they knew the story. They wanted to sue whoever hit them or whatever it was. So when I would push on their belly, and they knew I was pushing on their belly, they'd tell me their belly hurt. But when I would push on them, when they didn't realize I was pushing on their belly didn't hurt. So I was always sneaky. Whenever I wanted to test somebody's belly, I would do it by pushing while I was taking their pulse. And I would find out what they would do. I was a sneaky little booger. Okay, so rebound tenderness means a ruptured viscera. And you can do this like with appendicitis. There's appendicitis, and then there's a ruptured appendix. Now, this isn't trauma, but if your appendix is inflamed, it's going to hurt when you push in, but when you let go, it doesn't hurt. If that appendix ruptures and poop is all out in your abdomen and you're getting peritonitis, does that hurt? Now you've got peritonitis and you've got rebound tenderness. That means something ruptured when you have rebound tenderness. So abdominal trauma, abdominal injuries, you can have massive hemorrhage. The spleen is the most commonly injured abdominal organ. It pops the most. The liver and pancreas are also very, very frequent. And any hollow organ can rupture. And it's just due to high pressure that the abdomen gets hit and they just pop. If it's your stomach, you'll have blood in your NG tube. But you also can get blood in your NG tube from swallowing blood. So if you put down and when I say NG, I probably mean OG. All right, because we don't put a lot of NG tubes down on traumatic patients. But if it's stomach, if it's swallowed, it'll clear within just a couple seconds. You put it down, it comes back bloody, but then the blood clears, the stuff they swallowed clears, and then you get stomach looking contents. But if it's from their stomach, it will continue to have blood from it. So a lot of times that's important. Is it something they probably maybe swallowed, or is it something that is continuous and you know it's from the stomach? Okay. A ruptured bowel that isn't repaired, they will develop peritonitis, necrosis, and will probably die from it. So you've got to know, they have to go to the operating room if there's any signs of that at all. So it's not something that we fool with if we suspect it. So when we're talking about a ruptured viscera, we're talking about a high degree of hemorrhage. We're talking about a rigid board-like abdomen. That is how abdominal hemorrhage, abdominal bleeding, intra-abdominal bleeding. It's not, some of you all like to, I think it was you all like to answer bruises across the abdomen when you give heparin. That is not abdominal hemorrhage. That's tissue trauma. Abdominal hemorrhaging is rigid board-like abdomen, blood in the abdominal cavity, and they're guarding. You can't push it. Their abdomen's hard as a rock, and they are hemorrhaging. It's a C problem. It is hemorrhaging. It's a C. And their problem is fluid volume deficit due to disruption of their visceral organs. So this is our goal. They're in fluid volume deficit. Our goal is that they will have adequate circulating volume. It's a C problem. Okay. So we know we're going to use a 3-to-1 resuscitation rule with IV fluids, or 1-to-1 with blood. We've already talked about that. So how do we know that they have adequate circulating blood volume? Our patient is either in hemorrhagic shock or hypovolemic shock. Hypovolemic can include hemorrhagic shock. If it's just fluid, like with burns or dehydration or something like that, it's hypovolemic. If it includes blood loss, it's hemorrhagic shock, because there's red blood cells going out with it. So we get hemorrhagic shock typically with trauma. All right, so how do I know? If my goal is to have effective circulating blood volume, what am I assessing in my patient that tells me that my patient will have adequate circulating blood volume? Well, let's look at the next slide. Number one, they will have stable vital signs for their developmental age. Now, right now I am talking about adults, okay? This is important. I will not accept a heart rate of greater than 100 on an adult. If an adult has a heart rate of greater than 100, they are tachycardic, and it is abnormal. Normal sinus rhythm is 60 to 100. If you are tachycardic, your body is telling you it is trying to compensate for low cardiac output. Remember, cardiac output equals stroke volume times heart rate. Cardiac output is your blood pressure. Stroke volume is the amount being pumped out with each beat times your pulse. If you drop your stroke volume, the amount being pumped out, you're losing volume, then your heart rate is the first vital sign that changes. Your heart rate goes up before you drop your blood pressure. When you get a heart rate greater than 100, your patient is in hypovolemic shock. But Janie, they had a car accident. They're anxious. No, they're not. They're hypovolemic. If you're anxious, your heart rate shoots up and comes right back down. You do not sustain tachycardia when you're anxious. You might go up, but you'll come right back down. Do not accept a heart rate of greater than 100. It is the body telling you they are still in fluid volume deficit. You will not accept on an adult a systolic blood pressure of less than 100 systolically. They are hypotensive if their blood pressure is less than 100 systolically. Their cardiac output is not sufficient if their blood pressure is less than 100 systolically. But Janie, I work in the nursing home and we have little 70-pound-year-old women whose blood pressures are in the 90s all the time. Most adults don't weigh 70 pounds. There are exceptions, but most adults don't weigh 70 pounds. That's a child's weight. And they might have blood pressures in the 90s. But the adult, the average size adult should have a blood pressure greater than 100. Really, really, really skinny ones might be in the 90s, but most of us aren't really, really, really skinny. In today's society, most of us are not skinny. You will not accept a blood pressure of less than 100 systolically. If it's on a test, whether it's mine, Jane's, or NCLEX, don't make excuses. Your patient is hypotensive. Why are they hypotensive? In the clinical area, maybe you're on a cardiac unit and they're on 15 antihypertensives. Maybe that's why they are. And there's a reason why we're doing it, but they're still hypotensive. But your trauma patient should not have a blood pressure less than 100. They're hypotensive. Okay. The other thing that happens with vital signs is they get a narrowed pulse pressure when they don't have adequate circulating blood volume. Why? Number one, their cardiac output is falling. They're losing blood out on the concrete. They're losing blood down in their pelvis. They're losing blood somewhere. When your cardiac output falls, your systolic blood pressure starts to fall. These special tissues in your carotid body say, decrease pressure. Vasoconstrict and shunt some blood up into your heart. And so that causes constriction, causes resistance coming out of your aorta. And when you meet resistance coming out of your aorta, it makes your diastolic rise. And when your systolic falls and your diastolic rises, your pulse pressure gets narrower. So the patient that's in fluid volume deficit has a narrow pulse pressure, which was very different than the head trauma patient does. And it's all due to fluid loss. Systolic drops because of fluid loss. Diastolic rises because the body's trying to vasoconstrict to try to shunt more blood to your heart. People don't die by going 140 over 80, 130 over 70, 120 over 60, 110 over 50, 100 over 40. They go 140 over 80, 130 over 90, 120 over 100. People die by narrowing their pulse pressure because the body's compensating, trying to keep the blood pressure from dying. But if you don't fix it, they're going to. Okay. Urine output. Normal urine output. Normal urine output is 1 ml per kilogram per hour. We use 60 mLs per hour as normal urine output for an adult. Those of you sitting there going, that ain't right, Janie. I learned 30. That ain't right. I learned 30. No, you didn't. You're saying, yes, we did. No, you didn't. Yes, we did. No, you didn't. You learned 30 is minimum urine output, not normal. Minimum urine output. Normal, we consider 60 mLs. I got news for y'all. It's been a long time since I weighed 60 kilograms. Okay. So 60 is considered normal. 30 is considered minimum. So what I don't want to happen is for you to be the nurse that says, oh, my patient only had 25 out this hour. That's just a little bit below normal. No, it's not. It's a little bit below minimum. Not a little bit below normal. It's a little bit below minimum. And remember that urine output comes from your circulating blood volume. Urine output does not indicate that your kidneys are bad unless you come from a kidney unit, unless your patient's kidneys are bad. But the average patient in the hospital, in order for your kidneys to be bad, 95% of your nephrons have to die. Do you think today my nephrons are here and tomorrow they're gone? So why did today I have good urine output and tomorrow I don't have good urine output? My kidneys didn't die, you all. My circulating blood volume dropped and the kidney said, hell, I don't need them. Send it back into the circulating blood volume so she has good cardiac output. Your urine output drops because your circulating blood volume drops, not because your kidneys are bad. Unless you have kidney disease, then it does. But not, your patients don't have kidney disease. Your kidneys have decreased circulating blood volume. So when your patient's urine output drops, it's because they are dry, not because they're going into renal failure. Unless you have a reason to suspect renal failure. Now, you've been giving them some nephrotoxic drug that kills their kidneys, maybe. But probably 99 out of 100 patients whose urine output drops, it's because they are in fluid volume deficit. They need fluid. It's not their kidneys. Go check their creatinine. Their creatinine will be normal. So I want at least 1 ml per kilogram per hour. I want at least 60 mLs per hour. That's what I know there's having enough circulating blood volume. I want strong, palpable pedal pulses. If a patient has strong pedal pulses, if you feel their feet and they've got pedal pulses, that means they have at least a 100 systolic blood pressure. It could be 100, it could be 200. I don't know that, but it's at least 100. Pedal pulses are 100. Femoral pulses are 80. And carotid pulses are 60. So I have to have a blood pressure of at least 60 to be able to feel a carotid pulse. I have to have a blood pressure of at least 80 to feel a femoral pulse. And I have to have a blood pressure of at least 100 to feel a pedal pulse. So when I reach down and I feel a pedal pulse, I'm talking to my patient, I feel that they got a pedal pulse of 100. I know, by golly, that they have at least a systolic blood pressure of 100. They should have an improved level of consciousness. Your patient, your brain, a person's brain needs 2 things to live: oxygen and glucose. You've heard me say it before. How in the world does it get up there? Your circulating blood volume. If you don't have enough circulating blood volume, not enough oxygen, not enough blood glucose gets up to your head and your patient becomes confused. They've been oriented times 4 and now they're like, Sally, come in here, Sally. Sally. They're confused. They've been oriented times 4 and now they only know their name. But, earlier in the day, they knew everything, but now they don't even know their name. Chances are they're in fluid volume deficit. Are they bleeding out somewhere? Go check your assessment. What's going on with this person? They didn't have a head trauma. Why are they confused? They are in fluid volume deficit. Fluid volume deficit. Their skin should be warm and dry. They shouldn't be in vasoconstriction. They should be warm and dry. They shouldn't be cold and clammy. They shouldn't be vasoconstricting down, trying to shunt blood anywhere. They shouldn't be bleeding anywhere. They shouldn't have any obvious hemorrhaging going on. Nothing there. They should have a normal central venous pressure between 5 and 10. So that's a normal venous pressure. So if you run a CVP through a central line, they should have a normal CVP going on. And they should have a normal hematocrit and hemoglobin. They should have a good circulating, normal-ish hematocrit and hemoglobin. Now, there's different numbers for men. There's different numbers for women. We typically look at what's too little and what's too much. Typically, if you really want to know numbers and how to remember, I typically use a little saying, kind of. It's not a saying, it's just numbers. I say normal is middle age. Middle age is 35 to 45. I'm talking crit. I'm talking hematocrit now. Middle age or normal hemoglobin is those little early teen years, 13 to 15. I say this says 12 to 14, but 13, those little teenage years, 13 to 15. Okay, but hematocrit, we deal with hematocrits a lot more than we do hemoglobins, okay? Normal hematocrit is 35 to 45, those middle age, 35 to 45. When you get old, when you hit about 50, you start to dry up. Your skin gets dry. Your vagina gets dry. I mean, let's just face it, it does. You start to dry up. So when your hematocrit gets about 50, your patient is dry. Okay? And they're in fluid volume deficit. Okay? Now that's usually for just not hemorrhagic, but hypovolemic shock. When somebody's hematocrit is high, they're really dry. They're in hypovolemic. So if 35 to 45 is normal, add 5 onto it, around 50. When your hematocrit drops less than 30, you need to be transfused. So when you drop in less than 30, drop down at less than 5. Under 30, we transfuse. A hematocrit less than 30 gets transfused. So if you can remember 35 to 45, get old, you're dry, drop less than 30, you need blood. I don't know if that'll help you to remember. There's so many lab values to remember, but that's kind of how I remember hematocrits more than how I learned hematocrits is when you get old, you get dry. Not enough hematocrit, you got to have blood. All right, y'all, it is 1:51. It's time to quit. No. Yeah, it's time to quit. That's right. We've already had a break, haven't we? Yeah, we quit it too. That's right. It's time to quit. I will see you all on Friday morning at 9 o'clock. We're going to finish trauma, do chest trauma, and then we're going to do blood administration and sepsis in the afternoon. I'll stay online and ask if anybody has some questions. Okay? Bye, y'all.
Thank you. Thank you.
Jenny, I had a question about kind of the beginning of the lecture when you're talking about the airway and the C-spine.
Sure.
I guess, is it gonna differentiate between C-spine and then the other part of the spine in the question, or if it's the lumbar or T-spine, are you expecting to see something different? Or I know you see different injuries, but will it go down the priority list if it's a different part of the spine?
Well, the other part of the spine does not fall within A. It does fall into the more in the secondary survey,
Okay.
but immobilization of the entire spine is important at all times. So we do not sit up a trauma patient ever. We can log roll them on their side, but we do not sit them up.
Okay, thank
So
you.
you can't say, well, we could sit you up but we can't sit up a trauma patient until we're sure that their spine is cleared all the way through. Does that make, so I guess immobilization is all of them, but C-spine is really the highest priority because that can cause you to be a quad, but we don't want to set up any of it. We got to protect the spine through the whole thing.
Okay.
Okay. Anybody else? No, any other questions? Boy, I must have talked good if I don't have any questions. Talked well, talk right. I don't know what the word is. Nothing else? All right, I'll see you all on Friday then.
Sorry, I was just gonna say really quick, like when we're getting medic reports from like an NBC and all that stuff, I was thinking of what you're saying, like highest heart rate not above 100 and lowest blood pressure like not below 100. Is that why we always ask like the medic report, what's your highest heart rate and your lowest blood pressure? Okay, that makes, I'm starting to like tie things together now.
Starting to make some sense, huh? Mm-hmm.
Thank you.
This isn't on lecture, but I don't think it was last semester, but I think the semester before that. I was up in the MICU. This is on the test, but sometimes when you're in the preceptorship, the preceptors don't always do what we say. Okay. And so we were in, I think it was a MICU, but I'm not sure if it was a MICU or not, but my student said, I want to talk to you. And I said, okay. He said, and he liked his preceptor. It wasn't that. He said, my patient's urine output is like 15 an hour. And I kept saying to my preceptor, says, I think he needs fluid. And she kept saying, no, his heart rate's not high enough. He doesn't need fluid. His heart rate was like 90 or whatever. And he said, I think he needs fluid. I think his problem is he needs some fluid. And she said, nope, doesn't need fluid. And his creatinine was fine. His labs didn't show any renal impairment or any reason why his urine output should be down. And he said, Janie, I don't think that she won't listen to me. So, I said, well, you know what? She's the primary nurse. You're not going to convince her. I said, but let's look at the patient. So I don't remember what was wrong with him. I said, well, let's go to his MAR. And he was on a really high beta blocker. I said, what's this beta blocker doing to his heart rate? He says, it's bringing it down. I said, right. So if she's using his heart rate as its indicator of dryness, the beta blocker is not going to let him be tachycardic. So he probably is dry, but he's not going to have tachycardia because of his beta blocker. So he called the next day when I rounded, he said, the docs came by later and when she pointed out his urine output, they said, oh my God, he's dry. He needs some fluid. Why didn't you call us? We needed some fluids. And she said, but his heart rate went up because he's on a beta blocker. He's not going to get that. Because Jenny, you were exactly right. I said, okay, you got to look at the whole picture. You can't just say he's not tachycardic, therefore he's not dry, because he had a drug that wasn't going to let him be tachycardic. So it was really interesting, but that, I don't know, so you have to look at the whole picture, but that's part of the pictures. Tell me what his highest was and what his lowest was. So you have to look at the whole picture. But I remember thinking, yeah, I know. Yeah. And I could be just as wrong, but when you go looking for everything why wasn't his heart rate up? His heart rate should have been up. Why wasn't it up? So you have to, there's always that gray area you have to look at. So, okay, I'll see y'all. Anybody else? Bye, everybody. Oh, let me quit recording. Okay, stop. Bye.